my first real thanks to the members of the committee. They stayed on time amazingly well. I think this is the first group that I've ever had that actually did that.
He was very threatening, by the way, in emails before the session.
It was Jeff that was threatening. I was just a nice guy. I wanted to give you a chance to ask questions of your other committee members just to kick things off here, but I thought I'd start with a couple along the way. A famous old saying, it's attributed to Paul Batal, and it actually comes from a guy named Arthur Jones. Every system is perfectly designed to achieve the results it actually gets. That actually comes from a guy named Arthur Jones, and Paul got it from him, as we discovered a while back. So if that is true, you can run a system backwards. You can tell what its purpose is by seeing what it's actually measuring and responding to. What is the purpose of the current CMS quality measurement system? Now, I'm going to give you a hypothesis, and I'd like your response to it from each one of you. I believe that arguably on its basis of its results, what it achieves, that the main purpose of CMS measurement system is to reduce pay and save money. That they're really payment reduction systems pretending to be quality measures, surface antigens, a surface patina of quality measures, because that's primarily what they achieve. In fact, in some of that legislation, the HAC legislation, it's part of the legislation. 25% of the hospitals have to be penalized, 1% of their total Medicare payments, so that they could score it with CBO and show it as a budget savings. Thoughts on that? What do you think? Because that's what it primarily does.
I'm happy to begin. I have a poster in my office now in my house that John Eisenberg gave me, my mentor, who passed away sadly many years ago, of a New Yorker cover of an orange juice glass that you can interpret as being half full or half empty. I have to preface by saying I'm a half full girl, so is John. I don't buy that. I think the intentions are good. I think the intentions are to, in fact, deal with some of the real concerns that are out there about quality and safety in America. I think we have been severely limited by a data infrastructure that has been over-reliant on claims, that has been driven by sort of a measurement frenzy to feed the beasts at times, resulting in measures that may not always be the optimal measures. But I don't think that's actually the intent. I think we've seen enough evidence that, and again, I think we tend to get so focused on hospital. I mean, there's been significant improvements in other settings as well. And I think those are real, and I think those are by having true measurement systems, nursing home care and other examples of where I think the measurement approaches have had more of a quality impact. I'll leave it at that.
Bob, I can tell you.
Yeah, no, I disagree, I think, because there's a much more effective way to reduce spending. It's you reduce payment levels. That's been the tried and true way, and to sort of embark on this sort of whole venture into measurement, I think, with Helen, I think it's well intended. And I think it comes out of the accumulating evidence over many years about uneven and even substandard quality, and buying. In fact, I still remember an editorial by Arnie Epstein in the New England Journal, and now must be about 14 years ago, in which he said that pay for performance has compelling logic. And I think there is compelling logic, it just doesn't work. It is one of the, it's, I think it was, so I think it was well intended, and I would just point out that at least in some of the programs in Medicare, it is upside only. In Medicare Advantage, there's star ratings, you get extra money, nobody loses. So I think there's some sort of variations in how measurement is being done and for what purpose, but I'm not sure it's largely to reduce spending.
A follow-on to this, Steph, did you want to respond to that?
No, I agree.
You let it go. Okay. Another chance to get another viewpoint from the group out on the table a little bit. I wanted to set up a bit of a contrast between the group who came before us and us. They focus mostly on financial issues. We focus mostly on quality issues, on clinical outcomes, presumably. If I listened to the last panel, you would have believed that the whole thing driving the system were financial incentives. What is the role of financial incentives in the care delivery system? Now, you need to know in my own mind, I'm channeling Dan Pink here in his famous book, Drive, about what really incentivizes healthcare professionals. Thoughts on financial incentives as a primary tool to drive a quality agenda?
I'll start.
Okay.
I mean, I think this goes back to what we've been talking about with the improvement versus selection issue and how you define, we're talking a lot about value-based payment. It's a great term, value. What do we mean by value? And I think one of the concerns that we've had, and perhaps the limitation that our panel is trying to address in response to the first panel, is that the way we're defining value is fairly unclear, and most people are pretty unhappy with it. Almost everybody's unhappy with something about the way we're defining value. And if we look at the selection measures themselves, so many of them are supposed to be based on the improvement measures, but either are too slow to actually drive improvement or are too narrow to actually be useful for selection. And so we're sort of stuck in this middle compromise place where nobody is happy. And as a result, our payments are not driving quality the way we want them to. And so instead, we're relying much more on a lot of the financial performance. So if we're looking at shared savings, that's great. Or if you take a step back and say, what does CMMIs charge? They can either support programs that have higher quality at the same cost or lower cost with the same quality, or both. You sort of get the, boy howdy, better quality, lower cost, but most of them are doing one or the other. And the way we're measuring either of those is sort of leaves something to be desired.
Yeah.
Yeah, now I have mixed feelings about the answer to that. Sometimes I look, let's say, internationally, and all the countries that spend 50% less than we do have a whole variety of payment systems. Some have pure capitation, some have pure fee-for-service, some have budgets, hospital budgets. And yet they sort of are comparable in how they spend and even on many of the quality metrics, although there's some interesting variations based on the uniqueness of their payment system. That said, I think there are some inherent perversities in fee schedule and volume-based payment models, and one of the things I find interesting is that 30 years ago I practiced under primary care capitation with 25% withholds. I mean, this was real stuff, risk, capitation, and it wasn't done well enough because there was no risk adjustment and they didn't have trim points and there were some things that could have been done better, but then I hear everybody needs training wheels to do what was quite standard a couple of decades ago. I would like to get on. My concern about all these sort of intermediary steps that don't get us very far. I mean, I think we need to clean up the perversity in our fee-for-service systems, especially the physician fee schedule, where we should do better to correct the distortions there, and then provide one or two clear alternatives for those organizations that have the culture and are willing to change their business model to function under those, so population-based payment models. And a lot of I wish we could get through all the training wheel stuff and the on-ramps and get on with it.
Applause from the front row. I think it's an interesting question, Brennan. It's not one that I think you have an easy answer for. I think there are both extrinsic and intrinsic motivations. And I think we have spent a lot of emphasis on extrinsic motivation to improve through payment, many of which have not been successful. For those of you who weren't up at dawn like me reading the great piece this morning in the Annals by Mick Williams on the value modifier showing no effect. This is an area of research. This is really important. We need to get this right. And I think that a lot of these training wheels have also been experiments. And I think we need to understand what the right balance of how do we at times use extrinsic motivation when it's helpful, but I think we haven't done enough, to a lot of your earlier points about taking advantage of presenting data that would be useful for intrinsic motivation for improvement, and think about ways to bring those pathways together. Because I still believe that the best way to achieve what we want to achieve is by taking the measures that would drive towards improvement rather than the ones that come from a pure selection vantage point, and think about how to use those in a way that get at accountability.
Okay. Your turn. Comments or questions from the audience? Wow, that's a pretty fast, good response. Let's go front to back, if we may.
Hello, Stacy Bridges with Veterans Vision. I'm going to come from two different angles right now. One from a policy standpoint, and another one from a victim, patient, witness. You talk about measuring data and people not trusting the data or asking people versus statistics, trusting them rather than statistics. What role does block data, missing data, misinformation, and fee for pay and incentives play in the high suicide rate, the homicides, the heart attacks, strokes, suicides, diabetes? You were worried about Helen's mother being able to go to a bridge game, but the medication that they may be giving her may cause confusions, delusions, hallucinations, brittle bones, falls. So she may not be able to catch that bus or, learn how to play bridge or any other game because of the medications that were given and because of the misinformation. For example, my fiance died in 30 days after a doctor gave him a free sample of Abilify for stress. He was a CPA with an MPA. We didn't find out until we went to the hospital to get his stomach pumped that this was actually a schizophrenic drug that's been off-labeled to treat other disorders, be it stress, ADHD, autism, and these very drugs are on TV right now. And you got direct-to-customer, where you're telling the customer, well, if your leg itches, you need this drug, take this drug, and they downplay the side effects. So what role does missing data, block data, profits, and incentives contribute to the mortality rate? And what responsibility do you take as physicians?
One of the things that I personally believe, it's been my experience over the last 30 years with some real successes, it has to do with the true definition of transparency. It's the ability to build causal linkages, believe it or not. Now, interestingly, I disagree with Bob a bit. I believe that you do manage what you measure. It's just that some things are visible to the naked eye. Many things are actually visible to the naked eye. There's a classic old article in British Medical Journal, great tongue-in-cheek, dry British humor about parachute jumping, where we have no randomized controlled trial evidence of benefit and the potential that there's an iatrogenic effect at work there too. They call for randomized controlled trials of parachute jumping. The reason it's so funny is you can see the causal linkages with the naked eye. There are many things in my life that I don't need a measurement system for because I can directly observe. If I can't directly observe it though, or I don't have a measurement system, it's completely unknown to me. Many of the things you're talking about fall into that category. And what you learn from a lifetime of practicing medicine, I think any clinician in this room would agree, anything that's powerful enough to heal can also harm. And I personally believe that one of the most important things we'll do in the long haul is make care more transparent down at the level where the action happens. It's not so much ranking physicians, it's helping the physicians see what's happening as they counsel with patients. You're really targeting that dyad. You want the data to go to the patients, but nearly always they translate it in the context of an advisor. You have to hit them both. So I've dedicated a fair bit of my life to figuring out ways where I can really improve our ability to see those linkages. So much is invisible to the naked eye. Other comments from the group around these issues?
Just one brief, and I'm very sorry for your loss. That's really tragic. I think one piece of this, I think a lot of what Brent is pointing out is true. A lot of that is just not visible. We may not always know what happens there, and I think I just want to make one point, which is I think that patients have a huge role to play here in terms of putting light sometimes where there's been darkness. So I've done some work for the last couple of years with an organization called Patients Like Me, which is a consumer group in Boston. I think it's now 700,000 patients online sharing information about their diseases, et cetera, their symptoms. They're now one of the largest submitters of adverse event data to the FDA. Patients online giving information that, frankly, I don't often know about the side effects of drugs. I know everyone from my mother because she tells me everyone in great detail. But there's a real opportunity here, I think, as well, to empower patients to be a vital source of this information as well. But thank you for sharing your story.
It's a great idea.
And my quick comment would be that one of the reasons I support the potential, anyway, of ACOs, accountable care organizations, is that there is this organization between the payers and the clinician on the line who can do things theoretically like monitoring prescribing, identifying misuse of off-label drugs, that's not anything that CMS at Baltimore is going to be doing or should be doing, and Sam's gone, but I doubt that United Healthcare will do it. But at the level of an organization where there's a medical director who can use data and actually interact with the clinicians, it seems to me there's a real potential there for trying to improve care. And so that's why one reason I like the ACO concept.
So time for a blitz chess here. We're running out of time. So this person right here, one back.
In the back, or me?
Okay.
She asked the other question. Okay, I'm Ann Irving with the Premier Healthcare Alliance, and I want to commend the planners of this particular panel, and I'm sure the whole web conference, for having such a diversity of opinion on these panels and different stakeholders. I particularly resonated with Dr. Berenson's, what he said, contrarian positions. I mean, I think we've got to bring them forth in our planning and whatnot on metrics, but the one I want to pull out is the one about that metrics at the individual provider level, we're just not ready for it and it's not appropriate. As you know, medicine is a team sport, and the attribution of a case to a particular provider, it's really messy, okay? And so, you know, you got 5 doctors, 20 in a group. Who gets the blame for a particular misdiagnosis or whatever it might be? So my question is now turning that into Dr. Bernstein. Is the AMA and is your group of specialties going to fight that, or is it too late? Is the horse out of the barn? I mean, you can't fight it.
I didn't know that's where you're going to go. I think it's a really valid point, and I would very much like Stephanie's perspectives on this. I've learned a lot over the years at NQF, being around many stakeholders, including consumers and purchasers, and I think this is a really complicated issue. I think there are times when, in fact, you do want to know the performance of an individual clinician. I think an example of that would be surgical volume, for example. So I don't want to throw the baby out with the bathwater. I think there are some clear examples of that. I think, you know, the rapport you have with a clinician, their, you know, your ability to relate to them, patient reports, I think are things that could be individual as well, but I think we clearly have to move to much more of a team sport and really thinking about how care is delivered that way.
We're out of time. One more?
Sorry.
Okay, Jeff. You were up next, and apologies to those of you.
Thank you. I'm interested in the panel's comments about the ownership of the data to level the playing field to be able to benefit from the information that comes out of the measurement. Right now, it seems that we have claims data that's owned by the payer or systems data that's owned by the healthcare system, but it makes it very hard for the individual clinician at where the rubber meets the road level to utilize this data. What do you suggest to level that playing field and to allow access to the data for the purposes of making good clinical decisions?
I think that might actually be a question for the next panel, which is about EHRs.
That would help us with the time.
I mean, just,
I'll say one thing. Having been through the battles over the years, I personally believe that patients own the data. I believe that care providers have a legitimate legal interest in having a copy of it, mostly for legal purposes, for research purposes, for the performance of their own system. But I think the core background principle that I'm personally convinced is that those data belong to the patient, and they should be able to move with the patient in an easy, straightforward way. We're actually back to what I said earlier. I think that level of transparency, for me, it's data systems that are embedded. It is the EHR panel coming up, actually, Steph, that's exactly right. But I think we're about to see a major transition in EHRs.
yeah, and I think some of this does go beyond just EHRs. And just maybe one point, I think there's a lot of data that could be liberated that is not just in EHRs. There's claims data that increasingly we're seeing coming out there. I think we need to do that responsibly, though, and I think we need to always be careful about unintended consequences of how data will be used. So I think we have to collectively agree to some principles and some guardrails about how those could be used, but the principle of data liberation should be out there to drive improvement.
Let me say thanks to my expert panel. Thanks for your comments. Thanks for your questions. Well done. Back to you, Jeff.